Okay, welcome to this medical education webinar. Today, October 23rd, 2025, planned by the Sudden Arrhythmia Death Syndromes, the SADS Foundation. Today's panel discussion is entitled Long QT Syndrome, Diagnosis and Treatments, Addressing the Gaps. This webinar is being supported by a grant from Thrive Therapeutics to the SADS Foundation. I'm Marcia Baker, the Program Director with the SADS Foundation. Before I introduce you to our panelists, we'll share a story of a patient living with long QT syndrome. Volume's not up, Aaron.
My experiences with you today. I first noticed my symptoms back when I was 16 years old in high school, and I was in great shape, but still was unable to do the same thing as other kids could, like run a mile. Gym teachers would always tell me I'm going to fail my class if I'm not able to do it. I am so lucky that nothing ever happened to me. A few years later, in 1984, my sister Lenny, while in the shower, had a syncopal episode. She had been ill for some time and been put on erythromycin, a common antibiotic. Because she was undiagnosed with long QT, she wasn't aware that this antibiotic could have potentially deadly effects for her. She was taken to the hospital, which later her sympathetic nerve was cut, and they gave her a pacemaker and started her on antibiotic, or started on beta blockers. Sorry. She has experienced ptosis and permanent drooping of her eye ever since. After this episode, she was diagnosed with long QT type 2 and told me that I would also need to be checked for this heart condition. I ignored it at the time. A few years later, I was elk hunting with my brother, and as we were packing out from the canyon, I exerted myself for a long time, not eating and replenishing my fluids, which affects my electrolytes. I found myself getting weaker. As time went, I got separated from my brother. As it started snowing, I continued to make it towards our camp we had set up earlier, but before I could make it back, I fell to the ground, weak, exhausted, and unable to move my body. My heart feeling weird. I lay there, aware of what was going on, but numb all over. My extremities were cramped up and unable to move. I was scared, not knowing what was going on. Being alone. As minutes passed, I regained back to where I was able to continue on. Years later, when hunting again, I found myself in a similar situation, but a little different scenario. Just as the first time, I didn't have a good meal. I didn't drink enough fluids. I exerted myself to the extent to where I was feeling weak and lightheaded. I was with my wife and my father-in-law at the time, and we were all on horses. As we got on our horses to head out, I remember we went a little ways and just slowly fell off my horse. They stopped and asked me what was going on, and as I lay there kind of under my horse, again, my whole body numb, tingling hands, curled up, and but unable to speak slightly and to tell them that it should pass and I'll be okay, in which I hoped it would. It did, and then we were able to continue on. At this point, or at this time, I knew that I had to make an appointment with the doctor to know more, and not knowing how my life would change from this point. After my diagnosis, which confirmed that I had long QT type 2 as well, my doctor decided I needed an ICD implanted and put me on a large dose of beta blockers. I felt the effects immediately all the time and felt run down, drug out, and tired. I begged him to change the dose, but he was reluctant because of the cardiac episodes that I had experienced. This is what beta blockers was supposed to make me feel like, to keep me safe, I guess. I was on a large dose of beta blockers until the last few years. To this day, if I'm relaxing, I feel okay. But if I want to do something active, like play with grandkids or anything else, the tiredness and sluggishness will affect me. to feel crummy from medications or to have no protection is not a great choice to have to make. Many people in this family are affected. 3 of my 4 kids have long QT as well, and everybody's impacted differently. For example, my daughter feels the effects where my sons don't. My grandkids are also affected, and I worry about they might experience the same issues I have. I want them to be protected without facing consequences from beta blockers or shocks from an ICD. I don't want them to feel crummy. All of us with long QT deserve a better quality of life. Thank you for this opportunity again.
Okay, now I'd like to do some introductions. First, our moderator today is Dr. Barbara Troupin. Dr. Troupin has worked in drug development over the last 20 plus years, most often for cardiovascular and metabolic therapies, and now works with several startup biotech companies supporting their clinical and regulatory strategy development. Dr. Troupin has provided consulting support to Thrive Therapeutics. And each of our panelists now I'd like to introduce. First, Dr. Peter Aziz of Cleveland Clinic. He's a pediatric electrophysiologist and director of Cleveland Clinic's Inherited Arrhythmia Program. Dr. Aziz is currently the SADS Foundation's Medical Education Committee Chair and President of PACES, the Pediatric and Congenital Electrophysiology Society. Another panelist, Dr. Adam Helms, is an adult cardiologist at the University of Michigan. His primary interest is in seeing patients with inherited cardiomyopathies and channelopathies. In addition to his cardiology training, Dr. Helms also has earned a master's in human genetics. Our third panelist is Dr. Wojciech Zareba. Dr. Zareba is a clinician scientist and professor of medicine and cardiology at the University of Rochester in New York. He is a principal investigator for several NIH and corporate grants focused on cardiac arrhythmias, risk stratification of cardiac death, testing therapies to decrease risk of cardiac arrhythmias, and studying drug therapy or drug safety. He's the PI for the International Long QT Registry at the University of Rochester. So we are honored that our presenters are volunteering their expertise and time today. And now I'll turn the discussion over to our moderator, Dr. Troupin.
Thank you, Marcia, and thank you to the SADS Foundation for giving us this opportunity to have this discussion today. And thank you to our experts. So as we get started today, we're going to break this into a couple different pieces. The first one is going to be the patient's journey to diagnosis. I just wanted to highlight that we are trying to get a better understanding for the patient experience. And to that effect, there's a My QT Wave project that's ongoing to collect patient experience and perspectives. And take a look in the chat. There's a link to be able to see that program and have your patients participate or individuals with long QT syndrome as well. So thank you. And with that, let's get right into thinking about diagnosis. There are a couple different ways individuals can make it to diagnosis. Let's start with post-event presentation. So a patient has an arrhythmia-triggered event like syncope or cardiac arrest is seen in the ER. What is our initial approach to assessing underlying cause? So maybe I'll have Dr. Zareba start with his perspectives.
Thank you very much. I'm happy to be part of this panel. You ask about post-event situation. Obviously, every time patient experiences syncope and especially cardiac arrest and is brought to attention of emergency services or department, we are first of all focus on making sure that the patient survives. So resuscitation if needed, and all the measures that preserve life is #1 priority. After this initial attempt to save lives, we obviously ask the question, what is the reason? And as we understand, our audience is mostly medically oriented, we could start discussing it because based on the age of the patient. Imagine that the patient is 20-year-old who all of a sudden experience syncopal or even more cardiac arrest versus somebody who is in their 70s or around that older age. We have a little bit different approach and a little bit different suspicions. We have myriad of disorders that could fall into the potential causes of arrhythmia and cardiac arrest in young patients, but even more in older patients. So we first of all look from that perspective. So when we speak about mostly young patients, and as we heard in today's story, there was syncopal episode of sister of this gentleman happened in the shower, and this could potentially implicate maybe vasovagal, hot steam or hot water may eventually be creating kind of orthostatic drop of blood pressure. Doesn't have to be arrhythmia related, but could be. But at the same time, we could state that those sudden syncopal episodes might be a prodrome of more important diseases. And when you think about people at that younger age, who all of a sudden lose consciousness, even if we speak about syncope, not cardiac arrest, we definitely have to think about some potential arrhythmia-oriented disorders. And if you think along the line, hypertrophic cardiomyopathy would be the most common. And subsequently, we think about other inherited arrhythmia disorders, including long QT, could be Brugada syndrome, could be arrhythmogenic right ventricular cardiomyopathy. There are a couple of those suspected diseases. And what is the next step? Obviously, depending whether we speak of syncope cardiac arrest, the urgency of certain measures might be different, but ultimately there will be evaluation, cardiac evaluation, ECG evaluation, neurological evaluation if needed. As you may know, many of you, in number of patients, number of children with long QT, for years they sometimes were labeled with seizure related to possibly epilepsy or similar neurological disorders. And in our registry, we had numerous of such cases where for years these children were labeled as neurological disorders, not otherwise. So this is my brief introduction. I'll be happy to hear from Dr. Aziz and Helms whether they have some additional comments on that.
Yeah, thank you for those initial comments. Let me just ask if most of that workup happens in the hospital after the initial event, or do they pretty quickly transition to an outpatient workup? And then have Dr. Helms comment as well.
I believe that it depending on the condition, if we speak about cardiac arrest, it will be immediately follow. If we speak about ambulatory patient who had a syncopal episode 2 weeks ago, it won't be maybe done overnight, but it will be done quickly too. Adam?
Yeah, so I think you're also getting at, Barbara, how they might become to be referred to specialized centers. So I think it's highly variable, of course, depending on local expertise and practice patterns. But as you've heard from Wojciech, there are problems of both over and under diagnosis for long QT. We have the same observation recurrently where patients are mislabeled as epilepsy, and it makes just a huge impact on care, and having the accurate diagnosis in some of those cases can be quite tragic. There are also cases of overdiagnosis, and just as an example of those, we not uncommonly will get a referral for a cardiac arrest in a patient for whom long QT is diagnosed based on QT prolongation following the arrest. but then that later normalizes, and we know that this type of QT prolongation is more of an immediate stunning effect of the arrest and hypoperfusion. So we'll oftentimes make an alternative diagnosis. It could be CPVT, it could be arrhythmic mitral valve prolapse or cardiomyopathy. And those cases, I think, can be helpful to get an opinion from a center that deals commonly with inherited genetic types of disorders. And then I think another big reason is for in the initial consideration of ICD, even in patients who've had an arrest, it's not always mandatory to have the ICD, in particular for long QT type 1. So getting an opinion early when making these big decisions that are going to have ramifications for the rest of the person's life, getting opinions about optimization of medical therapy, and in challenging cases where Nadolol failure occurs, or as in the case presentation that we just heard, when it's tolerated very poorly and having a big impact on quality of life. And then finally, I think a big initial part of the workup for all long QT patients should be genetic testing. I think we'll get to this more later in the webinar, but really all patients should have a genetics evaluation, and oftentimes providers would prefer to refer to a center that does genetics routinely for that evaluation, or they may choose to get the ball rolling with genetic testing, but then a center that routinely uses testing may then be able to carry things on from there after the test has come back.
Thank you. So we talked a little bit about a presentation driven by a specific event. I'll turn to Dr. Aziz. What happens, and this may happen in your pediatric populations as well, when somebody else in the family has had an event and that you're getting referred family members for assessment? So they've not had an event, but how do you approach that patient population, or somebody that's been picked up on another screening modality, perhaps looking at EKGs?
Yeah, it's an important question. First and foremost is thank you to Saj for the invitation to be here and learn from our experts and from our audience as well. I think nowadays the most common portal of entry, honestly, for the diagnosis of long QT syndrome, and this is fortunate. I've even seen this evolve, and I'm sure Wojciech has seen this evolve too over the years. We're identifying patients that are asymptomatic much more commonly now than we used to. Usually the portal of entry, 30 or 40 years ago was a sentinel event that was very concerning, either an arrest in the index patient or even unfortunately a death, and then you're left with picking up the pieces of figuring out why after that event happened. I think nowadays what we see more of is either patients getting ECGs for other reasons. Non-cardiac chest pain is a common one in children. And I think screening is becoming more of a ubiquitous thing, whether it's mandated or whether it's family driven. We oftentimes see patients that are not symptomatic that have QT prolongation, and that's how they're diagnosed. But I think the emphasis here, and I see a family member of ours on the panel here, the emphasis here is exacting the family history is such an important part of the process. As an example, we follow a family that had sudden death in the patient that I saw as paternal uncle. And for years, no one really knew why. He was a freshman living in a dormitory. His alarm clock went off, and he was noticed to be gasping by his roommate. Other than that, we didn't really have a history at the time, and it was sort of unknown why the patient had an event. And of course, his niece, the patient that I followed, had very obvious and diagnostic QTc prolongation. So connecting the dots there, we linked them genetically through the father, and she carries a diagnosis now. And again, she's asymptomatic and was picked up because she had a concerning family history, but is fortunately appropriately treated as a long QT2 patient, and has not been symptomatic in the 12 years or so that I followed her. So that's the good news, is that we're able to now capture these patients way before they present with a malignant episode. And I think we we're getting better and better at identifying these patients before, they declare themselves otherwise.
Thank you. And is it generally the final diagnosis is made when you get a genetic result that's sort of confirmatory, or you've also got genetics that don't yield a definitive diagnosis? So maybe Dr. Helms can talk about what some of that may come back as in terms of where genetics fits in the diagnosis.
Yeah, great question. So, as I mentioned before, really genetic testing should be done for all patients in whom there is suspected long QT, and this impacts not only the patient's management, but also gives a more accurate screening tool for family members. So for patient decision making, we now clearly know that the stratification by long QT types 1, 2, and 3 is essential for estimating risk and response to medications. For family members, though, it also has a huge impact because we know that many family members may carry the genetic variant, but then not manifest a prolonged QT. So the genetic test really gives a 100% answer on if they carry the genetic risk or not, if they need to worry then about their children and so forth. And then on the other hand, if the genetic test is negative, then those family members can cross it off their list of life's worries. So it gives them relief and reassurance. And then finally, genetic test companies now sometimes offer free screening for family members, really reducing the barriers as compared to what it was like several years ago. So after the initial test is positive and the patient you're seeing in clinic, if they are responsive with letting their family members know, the family members can often have free screening for that variant within the next few months.
Okay. Well, good to hear that it's becoming more accessible. Let me ask Dr. Zareba. We've talked a little bit about the complexity and the variety of different ways that patients can present. I know you've done work in risk assessment, risk stratification. Are there specific tools that clinicians can use to help decide sort of depth of intervention for a given patient or family members?
Yes. First of all, what we just heard, history of patient events, presence or absence of syncopal events in the past. Secondly, evaluation of ECG with some degree of QT prolongation and possibly some other changes in the morphology of T wave, as well as information simply on age and sex is already important. If you combine age, sex, history of syncope, and ECG, and whether syncope happen on or off beta blocker, whether beta blocker were introduced earlier, those things are pretty much quintessential factors to evaluate risk. And as you mentioned, we have been working on that for decades, and number of papers were coming out of many hundreds, thousands of patients belonging to our large registry. We came up with some models, and we also came up with a calculator, which I could probably copy and paste on the chat in a moment. And this calculator pretty much takes into account those factors. And what Dr. Helms just mentioned, exactly, long QT type is also extremely important component of it. So all those few factors in this calculator, they could be entered by physician or patient, but physician, and there is some prolonged, 5-year estimated risk depending on somebody age, sex, QTC, genotype. Similar calculator has been, our calculator was cross-validated by Dr. Silvia Priori group in Italy, who is also amazing expert in long QT and other inherited arrhythmia disorders, and kind of reciprocating her help, we validated her calculator. They are very similar in terms of outcome. Her calculator is also pretty much combining 3 or 4 similar variables, and one could use either one easily, and they will yield similar evaluation of risk. And what we are mostly interested in, whether there is increased risk, especially of those life-threatening events like cardiac arrest or death. Syncope is also an event which we evaluate, but at the same time, we understand that the biggest fear is to have life-threatening events, as I mentioned. So those are oriented towards those events. So I believe this is what I would suggest, combining those factors or using calculator to help you estimate the risk for given age, sex, and other conditions, as I mentioned.
Thank you. And Dr. Helms, Dr. Aziz, as you're thinking about you've made a diagnosis and now you're beginning down a treatment path. Anything that you'd like to add to how you approach that? We've given some great comments about how the diagnosis assists in giving you a direction, but any additional as you're starting initial treatments for folks, what advice do you provide? What is your thinking? Maybe start with Dr. Helms.
Okay, thank you, Barbara. I'll give a brief response and then turn it over to Pete. So initially, we do try to do beta blockers for all patients, and as you heard in the introductory presentation, there's quite a lot of variability. Some people tolerate them well and can get to a target dose, and then particularly for the long QT1 patients, if they're able to get to a target dose of Nadolol and feel okay on it, then that's sufficient, and they can go on very effectively with that approach indefinitely. Other patients don't tolerate beta blocker well, and so then those are much more challenging and requires a nuanced approach. For a lower risk patient, we may tolerate a lower target dose of Nadolol and accept that that is acceptably lowered their risk from their baseline risk. Other patients who have higher risk, we may not accept that it has lowered their risk enough and need to consider adjunctive agents. I'll turn it over there to Pete.
Thanks. Yeah, I totally agree. I think beta blockers are the mainstay, first line. You don't leave the office door without really being started on one. But I think there's a bit of an art to that, as Adam mentioned, and as our patient story demonstrates pretty effectively. Going from 100 miles an hour to 0 is what a lot of patients feel like when they're on a beta blocker. So instead of giving them what we think would be target dose therapy, and I'm sure others practice the same way, we try to slowly introduce beta blockers into their system and increase gradually over the course of several weeks to maximize tolerance. But essentially at some point, most patients will describe some side effect, and that's what we try to titrate, maximum dose without side effect, which can be tricky in some. And as Adam also said, the ceiling there may be enough, and it often is for most patients, probably 80 to 90% of all patients, particularly the long QT1s, where the risk is lower and the response to beta blocker is quite high. That's typically all they'll need. Adjunctive therapies can include things like atrial pacing for patients with pause-dependent arrhythmia, like some of our long QT2 patients can have. Additional therapy, as was described by our patient story, can be a sympathectomy, where we remove part of the sympathetic chain. That is, I think, taking on more of a ubiquitous flavor for the high risk. I think it was pretty common to do years and years ago, fell out of favor, and now is being adopted again as a relatively routine therapy. And many institutions do that videoscopically, so the invasiveness, I think, can be minimized. And then for the higher risk patients, device therapy like a defibrillator can be employed. There are other medical therapies though that beyond beta blockers that some of us can use. Most of us use Nadolol for treatment of long QT1, and most often too, though propranolol may be more effective for long QT3. And for patients that still have arrhythmia events, we've seen data that mexiletine can not only shorten the QTC but help prevent recurrent arrhythmia. So that's becoming a popular medical additional therapy for those that are considered high risk or those that have breakthrough events despite therapy. So there are lots of things that are options, though for the most part, beta blockers do the job in the vast majority of patients alone.
So,
If I may,
Mhm.
I wanted to also stress extremely important aspects of lifestyle modification and precautions regarding medication. So avoiding all these stressors that could trigger catecholaminergic response, but especially medications which are so nicely listed on credible website. Those medication or education about medication should go toward patients, obviously, and patients should be educated, but also healthcare professionals and physicians and nurses who take care of this patient. I can give you an example from the study which was published about 4 years ago or 5 years ago from Denmark. Denmark, as you may know, has extremely well organized healthcare system with medical records practically for everybody, for everything. And they follow about, if I remember, 160 or 190 long QT patients, and they look at their ECGs as well as events. And once they follow them, they identify that half of the instances happen on medication which were generally not indicated for long QT patients. Many antibiotics, some antipsychotics, and few other medications. But bottom line, the main message of this article was that despite the fact that patients and physicians knew that patients had long QT, they still prescribe those medications. Sometimes you have to, but you have to be cautious if you have choice.
Oh, and thank you. That was the direction I was going to head in is, in addition to the diagnostic workup and beginning treatment, we've just talked about other meds that can prolong QT. What other sorts of advice are you providing to these patients when they get their diagnosis about how they think about approaching modifications to their lifestyle? So maybe I'll start with Dr. Helms.
So of course, Wojciech's already covered many of these. Sleep deprivation can also be a trigger for long QT2, and I feel like that's one that's not recognized by many individuals. So I would just emphasize that. And maybe part of the contributor, and Wojciech could probably comment more on this, but maybe a contributor to some of the postpartum risk for long QT2. So I also includes counseling about keeping consistent sleep. We've had at least a couple cases where that seemed to be a clear trigger for quite a lot of arrhythmias. And exercise is obviously always a big question that individuals have. I think one key thing is that we reassure people that they can exercise and should for the overall health benefits, but we help to guide them in as far as safe exercise practices, particularly for the long QT1 group. And obviously that's a very individualized discussion that could be a whole topic of a longer conversation.
And Dr. Aziz, you see a primarily pediatric population, so this counseling goes both to the kids and their parents. Are there other things that you're adding into those discussions that are helpful for families?
I think we hit the highlights. As a matter of fact, see many of the parents too. I'm an adult congenital provider too, so we end up following the parents as well. And it's the nice thing about it is of course our approach is personalized to the patient. Age matters, but a lot of what we counsel can be translated into a pediatric or adult patient. I think the pregnancy, the postpartum period is a clear known trigger. Many of our patients have been asymptomatic their entire lives, and postpartum is when they develop symptoms, and drug exposure, of course, is another big risk. We used to counsel long QT patients against exercise, and as Adam mentioned, there's reasonable data now to suggest that exercise in controlled fashion when you're under the care of a provider that is appropriately treating you is at the very least safer than what we thought it was. I think there's still risk, of course, but I think that can be mitigated by several things. And that brings me to the next and final point I'll make about this is that we always think of the worst case scenarios as providers. Where is a patient? How can they be intervened upon? Are there CPR providers around? Is there an AED around? These are practical conversations we have with families. So we tend to not restrict, rather we counsel and say, what would it look like if somebody had an arrest while playing soccer, for example? How prepared is that soccer team, the coach? Is the coach aware of the diagnosis? That's something that we emphasize. And is there an AED that's around versus swimming in open water as a long QT1 patient? Not only can you not see the bottom of the water, but how are you equipped if you're on a boat in the middle of the water to be able to do anything about it? So we tend to be a bit more cautionary in that regard. Probably one of the few examples where we don't have a lot of wiggle room, as swimming can be a pretty powerful trigger for long QT1, of course. But yeah, it's a very patient dependent conversation and a very genotype dependent kind of conversation as well.
Thank you. I'm going to move into sort of future directions, including kind of what are the gaps? What are the tools that you still need? These are individualized conversations, but what are some of your, if I only had something that could treat, or what are the characteristics? What are the areas where you wish you had additional tools that would be helpful in patients? I see Dr. Aziz nodding, so I'll start there.
As clinicians, and I guarantee that Dr. Zareba and Helms will agree and likely add on some other sticking points, I think is the best way to say it. Long QT syndrome is a chronic illness, and I think when we present the fact that this is gene and inherent and not going away, that's a bit of a wake-up call for most families. This is not a take medication for a little while. In most patients, I should say, this is chronic therapy for a chronic disease. And even though many patients do really well on beta blockers, many struggle. And short of sympathectomies to ameliorate some of the beta blockade that we're trying to achieve surgically, sympathectomy is not without caution, and it's surgery, and there are risks, as again our patient demonstrated. So I think we try to calculate all of these things, and we try to mitigate risk as we discussed as best as possible, optimize therapy, personalized therapy. But I think when patients leave our office, I imagine they struggle, and I imagine they need mental health support, which is something that is, indoctrinated in our clinic. Every patient needs that, of course, when they're dealing with, not every patient, but most, when they're dealing with something like this. So there's a lot more to it than the algorithmic protocolized treatment that we give. It doesn't land the same on everybody. It isn't as effective on everybody, even within the same family as genotypes have different penetrance. We have to be aware of that too. There's a lot of variables that mix into this that we can all talk about how strategic our treatment plan is, but it can be it can be quite variable and patients can respond variably to it. And that's something we always have to pivot on.
And I'll turn to Dr. Zareba, but several of you have mentioned the kind of titrating to a target effect of beta blockers. And is that more driven by just pure tolerability, or is there some corrected QT or heart rate? What are you looking at when you're titrating? Is it purely tolerability, or are there other factors? And sort of how does that factor into the potential for other therapies being part of this discussion? So I'll turn to Dr. Zareba.
Yeah, it's a very good question and difficult question to answer because there is no gold standard for what would be perfect for a given person in terms of beta blockade. We would like to achieve more beta blockade than less. For years, there were some recommendations coming at first from Dr. Peter Schwartz from Italy, indicating that it should be 3 milligram per kilogram of propranolol. It was kind of old formula at that time. And if you think about it, what we heard on the movie and we heard a moment ago from Dr. Aziz, obviously many patients may not tolerate full dose of beta blockers, and we have to accept that. But at the same time, beta blockade helps. I remember we published a paper, I think in year 2000, with Dr. Moss on effectiveness of beta blockers, and we look at the dose, and we divided our population by dose below median versus above median, taking each beta blocker separately. And the analysis showed that even those people who were at lower than median dose of beta blocker for the population were not that unprotected. They were still protected. So beta blockade is important because we would like to decrease this catecholaminergic surge, which frequently is associated with, emotion, sudden stress, and many things, including what we have heard, triggers like swimming and others. So beta blocker will be still our first line. You heard already about mexiletine, and what is the goal in terms of mexiletine is shorten QT. Beta blockers, they do not do that much shortening, whereas mexiletine definitely helps, and mexiletine has been reported helpful in LQT2 and LQT3 patients. So this is increasingly used, especially in people who have either higher QT duration above 500, or especially in people who already had cardiac events. And I wanted to stress again, based on some data from our registry, from the registry of also patients who have ICD with long QT syndrome, we have evidence that those people who have syncope while taking religiously beta blocker, they are at very increased risk of subsequent events and life-threatening events. So we are in the position of recommending ICD therapies if somebody, despite optimal dose of beta blockers, they still develop syncopal episode.
And you differentiated between effectiveness of beta blockers in patients with type 1, whereas less
Yes.
focused, less effective. As the clinical environment changes potentially with introduction of therapies that are more type 2, type 3 focused, what would you want that clinical data to look like to have that be compelling? What are endpoints that are of interest to know that you're getting a benefit in the LQT2 and 3 population? And if there's a quick comment from Dr. Zareba, then I'd like to hear Dr. Helms's thought as well.
I will quickly stress that obviously it's a rare disease. It's very difficult to conduct large randomized clinical trial, which will require hundreds, if not thousands of patients with the relatively low event rate. So we cannot really rely on this hard endpoint for qualifying given therapy. However, we have good enough data from many groups indicating that QT is to some extent good predictor of subsequent event, and increasing QTc by certain number of milliseconds is associated with increased risk of events. Goes more or less along the lines that per each 10 millisecond increase in QT, let's say from 460 to 500, you have 40 millisecond difference. The risk is increasing more or less 40%. It slightly varies by genotype. It increases more in LQT3 than 1 and 2 for the same range, but bottom line, this is good predictor. So reversing this concept, you would like to decrease QT because this QT is predisposing to arrhythmias. So we would like to achieve this shortening using any possible medication which could be available. I mentioned mexiletine. We used to test flecainide. This medication has also some long-term use side effects, GI upset, and a few other things like that. So we definitely would welcome medications that would be without major side effects and well tolerated, but shortening QT, I would say at least by 20 to 40 milliseconds. Yeah.
And Dr. Helms, giving you an opportunity to add anything that we may have missed.
Yeah, great. I'll just make a couple comments. So, totally agree that we have such strong evidence that the extent of QT prolongation correlates with arrhythmias. And just to reiterate that Nadolol or other beta blockers don't affect QT. They're sort of affecting downstream arrhythmic risk in the setting of a particular QT, whereas mexiletine is quite different. We think that the mechanism is specifically related to QT and highly variable between individuals. So there's some data for both long QT 2 and 3, but highly variable from patient to patient. I have one patient with long QT 2 in particular who appeared to have a reduction in QT with mexiletine, but then there's this known variability in the QT measurements from time to time, and after several repeated measurements, really there was no difference in the QT interval, and it does cause nausea and other side effects. So then she ultimately elected to stop the mexiletine. So in general, for QT as a metric for new drug therapies, I would share enthusiasm that a reduction in QT would be very exciting for the potential of that medication. And it is what we will need to use for clinical trials because, as Wojciech mentioned, there just aren't enough adverse events to accumulate that would feasibly enable a trial. However, I do think we should be a little cautious too, because it is technically a surrogate endpoint, and there's many examples in the medical literature of surrogate endpoints being, including our field of cardiology and PVCs, post-MI, and flecainide, that story, that surrogate endpoints don't necessarily correlate with adverse events. So I think we should be somewhat careful in extending the therapy very broadly for any new agent, and perhaps this may be a place where a trial was powered for a primary endpoint of QT, but then we establish registries for a longer term follow-up where we really make sure that the long-term story is that of reduced risk correlating with the reduction in QT interval.
Yeah, no, that's very helpful because it helps us contextualize for a rare disease population. How do you get tools that can start being helpful and have longer term follow-up? We started at the top. We also mentioned that patient-reported outcomes are also a big player, and there is an ongoing trial looking at ways to collect patient-reported outcomes that can then be validated and used in clinical trials. With the example being My QT Wave is one of those, and that's in the chat. Maybe we'll drop it in one more time for anybody that joined late. We do have a couple minutes. I did want to see if there were questions. Thanking each of you for giving us great insights. I know it's a lot to cover, and we tried to distill quite a bit into a short period of time. But if there are questions from our clinicians in the audience, we might be able to take one or two of those as well. Well, we're waiting for questions. Did I miss querying any topic that you think clinicians should know about as they're starting to think more broadly about long QT syndromes? So I think one other thing that would be interesting that I had thought about talking about earlier, and we ran out of a little bit of time, is I do think that understanding, that there are some other treatment options that may be more invasive, the ICDs or the sympathetic denervation. From a patient perspective, how do you feel that your patients are open to some of the more invasive therapies versus having an option of an oral therapy?
I would say, from the perspective of about few hundred patients we have in registry with ICDs, with some data on their perception as well as data on their follow-up. It very much depends on the prior risk of the patients, if they had already experience or family members experience cardiac arrest or sudden death versus people who are fully primary prevention patient without any prior events. So their approach is obviously different for ICD. And we, at the same time, understand that sometimes families, as probably Peter and Adam could confirm, could insist on ICDs because they lost already one child and they would like to have other child with long QT protected, despite the fact that the child didn't have syncope or maybe even didn't have very long QT. But we had number of cases in the registry of this nature. We tested this, we investigated and we found that in fact history of this particular child, of the child sibling is usually more important than the death in the family, but still it's major challenge.
Okay. So with this, I recognize we're coming up to the top of the hour. It looks like everybody has been absorbing all of the information, but the not having additional questions. So as you speak to your colleagues in the community, sort of when do you want to see these patients? When do you want to be able to engage in care with them? So when would you like them to be referred or come to you or seek out additional information? How do you want your sort of local community cardiologists or primary care thinking about when to refer or when to co-manage? Maybe I'll start with Dr. Helms.
Oh, sure. So, whenever they have questions or are feeling like it's not fitting with the profile or their comfort level or experience, but of course, we're happy to see patients whenever and either co-manage or see for one-time referrals or whatever would be helpful to the managing cardiologist. I mentioned some of this at the beginning, but the seeing a lot of cases can be helpful for borderline diagnoses, for developing appropriate risk stratification approaches, coming up with nuanced approaches to treatments, especially when Nadolol is not working out well for the patient, and of course for genetic testing and evaluation.
And Dr. Zareba, and then we'll finish with Dr. Aziz.
Generally, Since I just picked at chat room, there is a question: what is the reduction of arrhythmia risk in subject taking beta blocker? So the risk is dramatically reduced, I would say by 80%, especially in long QT1 patients, and to lesser extent in LQT2. LQT3, there are some conflicting data. From largest cohort, we found that it seemed to work better in women than men. We don't know yet fully why. So this would be my quick answer to the question.
And Dr. Aziz?
Yeah, just taking a stab at your last question. I'm totally biased, obviously, right? This is the world we live in and the passion we have for treating a pretty rare, though relatively nuanced disease. And I think even amongst, as we discussed, even amongst family members, the presentation, the phenotype, the treatment can be a bit different. So we welcome management of any patients with long QT syndrome. We work with referring providers. Many of our patients are able to come perhaps once, and I think that initial visit is so important because there's, as we discussed in this webcast, so much to go through, from medications to avoid, activities, how do we screen family members, what does a genotype mean in you, what is your QTC, what is your risk, talking about beta blockers, when to take them in the day is something that is not uniform. It is genotype dependent. In long QT1, we prescribe beta blockers in the morning and at night for long QT2 for trigger specific reasons. So all of these things I think have to be vetted, and these conversations are lengthy and in depth, and they need to be. And many of our providers simply just don't have the time to be able to provide the depth of counseling that we do in those initial visits. And then I think beyond that, issues of course arise in terms of managing their mental health and side effects with the beta blockers. So touch points after that initial diagnosis are also important. Yeah, so we welcome, working with referring providers as often as we possibly can.
Well, I recognize we're at the top of the hour. Thank you so much to all three of the panelists. I've learned a ton today as well. And thank you to SADS for facilitating our opportunity to be here and speak, and to Thrive Therapeutics for their generous support of this webcast. And I'll hand it back to Marcia for any closing words.
Thank you very much. I just want to say how much we appreciate, on behalf of the SADS Foundation, appreciate all of your insights and discussion today. So thank you, Pete, Barbara, Wojciech, and Adam. So thank you, and have a good rest of the afternoon. Goodbye.
Thank you.
Thank you, everybody.
Thank you.